Thank you for this opportunity to share our research. The authors have the following disclosures. PEG procedures have traditionally been performed under a sterile operative field. Our group recently questioned this given the non-sterile nature of the alimentary tract, and these procedures, despite the creation of a sterile operative field, would be classified as clean contaminated procedures. We realized that as one would forego a sterile operative field, which we call the clean operative field, that would not change the wound classification. And for the purposes of this study, a sterile operative field PEG is as demonstrated on the image on the left, a procedure where the patient is prepped and draped in the usual sterile fashion, and the providers involved in the abdominal portion of the PEG procedure gowned and gloved sterilely as well. In contrast, our clean procedures forego that sterile field, and the providers are using non-sterile nitrile gloves and no sterile gowns. Our group previously demonstrated in these clean versus sterile PEGs that there was no difference in SSI rates after these procedures. This was in an approximately 500 patients undergoing PEG, fairly equally divided between the two groups, and we failed to demonstrate a statistically significant difference between the two groups. So given this, we hypothesized that foregoing the sterile operative field with the accompanying cost savings in supplies potentially could result in a more cost-effective method of performing PEG procedures. So the purpose of this study was to evaluate the cost-effectiveness of clean versus sterile operative fields during PEG procedures. We created a decision tree model modeling clean versus sterile operative fields during PEG procedures as shown here. At the decision node, you can choose to do a clean procedure versus sterile, and based on chance or the probability of that decision would result in either a surgical site infection or not. The primary outcome of our study was the incremental cost-effectiveness ratio, or ICER, and that was measured with the ceiling willingness to pay threshold of $100,000 per quality adjusted life year, or QALY. The cost perspective was from the healthcare system, and the time horizon of our model was 90 days. Here are the parameters of our model. As noted, we had our retrospective cohort study from our group that we previously reported on that did not demonstrate a difference in SSI rates between the two groups, and we used the values from that study of an SSI rate of 2% after clean PEG and 1.4% after sterile PEG. We obtained the utility measures from a cost-effectiveness analysis registry, and we estimated the duration of the health states to aid in this decision analysis. As far as the cost data, we obtained that from our institutional database of patients undergoing these procedures and found that a clean PEG cost approximately $1,700 from the perspective of the healthcare system. We had difficulty with the sterile PEG given that our providers that predominantly do these procedures also do tracheostomies at the same time as the sterile PEG. So we had to extrapolate the costs of the sterile PEG based off of supply cost for our facility. Finally, the additional cost incurred from when a patient sustains a surgical site infection was obtained from the literature in a previously published meta-analysis. In our base case analysis, we found that clean operative field PEGs were both more costly by a marginal cost of $100 and less effective. Now I have to note with the QALYs listed here, given that our model horizon was 90 days, a patient in perfect state of health during that period would have had a QALY of about 0.25. So as you can see, the clean PEG was both more costly and less effective and was dominated in our study. We then performed one-way sensitivity analysis on all our model parameters. These four parameters here are the only model parameters that resulted in changes in the cost effectiveness over the range studied. As you can see, if the probability of surgical site infection after a clean operative field rises above 1.6%, sterile operative field PEG remains cost effective. In contrast, sterile operative field must remain below 1.9%, holding all other parameters constant, and you can see the costs here. Finally, we did a two-way sensitivity analysis where we looked at the probability of SSI after a clean operative field PEG, as well as the costs of a clean operative field PEG. As you can see in the figure, in the majority of instances, a sterile operative field PEG was preferred. However, as shown here, if the rate of SSI after a clean operative field PEG was 3%, the cost would have to be below $1,380 to be cost effective. Conversely, if the SSI rate dropped to 1%, the cost must remain below $1,860. So in conclusion, based on our study, sterile operative field PEG procedures do appear more cost-effective based on our model parameters. However, this study does outline the circumstances under which a clean operative field PEG can be cost-effective. So as we noted in our prior study, it would appear that the SSI rates are similar between the two groups. However, this study did indicate that that rate cannot differ by any more than 0.2%. And unfortunately, our prior retrospective cohort study was not powered adequately to detect that difference. And so as a result of that, further study is necessary to test the assumption that clean and sterile operative field PEG procedures are similar in their SSI rates. Finally, I would add that you must also be quite familiar with the supply costs at your institution to determine whether it would be cost effective or not. At our institution, we use paper drapes, as in many institutions. Of course, cloth drapes would incur further costs, and it is possible that other supply costs could vary quite significantly between different institutions. I thank you all for your attention. I welcome any questions at this time.